Good morning, everybody. Welcome to our TMC Mama Chat. We have Dr. Richards with us this morning. We're going to be covering newborn safety and care. Good morning, Dr. Richards.
Good morning, Jordan, and good morning to all that are here. I'm excited to be chatting with you all, whether it's from home or your office or wherever you are.
Thank you. So let's go ahead and get started. We've got quite a few topics to cover today. First, I'd like to invite Dr. Richards to discuss a little bit about our NICU here at Tucson Medical Center.
All right, well, NICU stands for Newborn Intensive Care Unit, and this is for the babies that need intensive care. So whether they're premature and they're very sick, or they're premature and just needing a little help until they get more mature. We also can have term babies that also are having problems, whether it's a heart problem or an intestine problem or a breathing problem would be in our newborn intensive care unit. And that's basically what that means. Our unit has room for 41 babies, and sometimes we're full and get to that number, and sometimes we're quite a bit less. Our goal is to be family focused. And so we try to make it possible that families, moms, dads, grandparents that are visiting their baby have some privacy when possible. So we are able to have a private space where we have screens around the baby's space where moms can pump, provide breast milk. People can visit their infant with a little bit of a privacy with those screens.
Mm-hmm. Okay, thank you. And we're a level 3 NICU, correct?
Yes, correct. So we're a level 3 NICU. In the United States, we have level 1 to level 4. Level 1 is when the babies are expected to be normal. They're usually term. Level 2 is when they can be mildly premature, just a little bit, and might have some mild breathing problems or some mild feeding problems. Level 3 ramps that up a lot to almost anybody that needs a ventilator or might need blood pressure medicines and a lot of complications like that, especially extreme prematurity. And then level 4 is that highest level of NICU where sometimes they do heart-lung bypass or they do open heart surgery and recover in the NICU, or they do brain surgery and recover in the NICU. And that's a level 4 NICU. And the nearest level 4 around here is in the Phoenix area.
Right. And we also have a NICU transport team here at the hospital.
So our NICU transport team is made up of NICU nurses and respiratory therapists from TMC, and we support all of the areas in the surrounding southern Arizona. If there's a baby that needs our higher level of care, so we take care of babies that are level 2, level 3 care. And if there's a level 1 nursery that can't handle a baby, we will take our incubator, our ventilator if necessary, the oxygen that's needed, the oxygen tubing to go to that site, stabilize the infant at that site, helping the staff at that site, and then transporting the baby back to our newborn intensive care unit. That could be by helicopter or by fixed wing, otherwise known as airplane. And sometimes it goes by ground. It really depends on how sick the baby is, what the weather is like for flying, and how far away that baby is.
Okay, thank you. So, you know, Dr. Richards, most parents don't plan on having a baby in the NICU. It's not in the birth plan for this to happen. Everybody wants healthy babies that go full term, but sometimes that doesn't happen. So tell us about the first interaction that families might have with you, whether that be at a delivery that you guys attend over in labor and delivery, or for a consult before mom is in labor. Can you explain those two to us?
Right. So very interestingly, people thankfully expect a term birth and baby goes home with mom. But 10% of all babies born anywhere between 9 and 11, but 10% here at TMC end up getting admitted to the newborn intensive care unit for some length of time. Some of them are very short and some of them are quite long. And when a mom comes in to deliver, there is an assessment made of what is the chance or risk that the infant will need to be admitted to the newborn intensive care unit. If that risk is high or most likely, then they will bring us in to
We're having some technical difficulties. Just give us a minute here. We can't hear you.
Now do you hear and see me?
Yes, thank you.
Okay, nice. Okay, let me get my volume up so I can hear you. No, I can't hear you, but you can hear me.
Yes.
Okay, so I don't hear, but I will go forward, and then you might have to chat, text the questions, because right now I do not hear you.
Okay.
So if the delivering providers think that the baby is likely to be in the newborn intensive care unit, we try to meet with the families beforehand. And the reason we meet with them is to talk about what are the risk factors of coming into the newborn intensive care unit, how we will support you and your family and the baby, especially if the baby is what we call extreme premature, anywhere from 3 to 4 months early. Those babies are often in our hospital for 3 to 4 months. And so we will go through beforehand a list of the things that we will be monitoring and evaluating with the baby and how we will be supporting the baby. Then if there's a baby that's going to be very premature, which is what we call 2 to 3 months, we then talk about some of those things, but they're less than what we talk about in that extremely premature baby. And those kids are, in our nursery, again, about 2 or 3 months. What we generally tell families is that babies are in our newborn intensive care unit until about the due date, sometimes earlier if the baby sort of gets everything together and is ready to go home, and sometimes it's later. But even babies that are term sometimes have needs for being in the newborn intensive care unit. Sometimes when the obstetrician is doing the ultrasound, they see an abnormality in the heart, or they see an abnormality that is if those things are present, then those children would need surgery, and therefore we will talk to them beforehand and go through the plan of what we would do for your baby to support needing that surgery. In addition, we work with the pediatric surgeons in town to sometimes meet with those families beforehand so that there is less concern about what's going to happen because that has been discussed. So that's why we do consults. The next thing is sometimes we are called to a delivery. All right, we go to about 25% of all the deliveries here at TMC for women. And those deliveries could be because of prematurity. They could be because mother is having a medical problem that might be affecting the baby. It could be as they're monitoring the baby looks like there might be a problem at delivery. The baby's heart rate is too slow, or the baby's heart rate is too fast. Any variety of things that are happening. So when our team goes to the delivery, then we have a nurse from the NICU and a nurse practitioner or a doctor, usually from the NICU, to then evaluate the infant. Now, if the infant comes out beautiful and not needing any support, then we will leave the baby with mom and they can do their golden hour. If that baby is needing some breathing support or anything that needs a higher level of care, that's when we bring them to the newborn intensive care unit. Now, when we bring them over, it doesn't mean they're going to stay for a long time. Sometimes babies need just an hour or two of help with a little bit of oxygen on a little mask around the nose to help open up the lungs. And if we do that for an hour or two, then maybe the baby can maintain their breathing on their own and go back to mom's room. And we had a case like that last night. And the baby went out at about 4.5 hours of age. And so that mom was able to spend the rest of the time for the evening and today so far with her baby.
That's great. Thank you for telling us a little bit about kind of how the NICU works alongside the other units. Let's go ahead and move into screenings for baby. After a baby is born, tell us about a couple of the screenings that happen for baby or testing before baby can go home.
All right, so some of the screenings we do, so what I tell families, especially in the newborn nursery, there are 4 standard screenings that are done with babies before they go home. The first one is what's called the critical congenital heart disease screen. So this is a screen that's evaluating for a change in the heart that can happen after birth. So in the womb, the heart is not used a whole lot. All of the blood pressure, all of the blood flow really comes from the mother's blood pressure through the placenta and through the baby and out. So there's a little bypass valve that nature has made in babies called the patent ductus. That bypass valve needs to be open as a fetus. Sometimes the heart develops abnormally, and when the baby is born, when that bypass valve closes, then the baby can get very sick and get very blue and have a heart rate problem. The critical congenital heart disease screen is when we check how pink the baby is in their hand on the right hand and in any one of the feet. If those numbers are close together and high enough, we can be fairly sure that that bypass valve is not going to be a problem if it closes. Usually it's closed by 24 hours of age, so that critical congenital heart disease screen is done at 24 hours of age. It's a bedside procedure. You don't have to take the baby away from the mother-baby unit to do it. This does not rule out some of those little tiny holes in the wall between the ventricle or a little tiny hole in the wall between the atrium, because those are not critical heart disease problems. They're mild and babies can handle that very well. So if people say you passed your critical congenital heart disease test, that doesn't mean everything is totally cool. As the baby's blood pressures change up until 3 to 5 weeks of age, a murmur may show up later as those pressures in the lung and the body change. And that's when the murmurs show up. A second test that all babies have done is what's called the genetic disease screening. There are 28 tests that the state of Arizona does with what's called blood spot testing. There's a little card that is brought to the baby's side. We do a little heel stick and then get some blood drops in 5 different circles and send it to the state lab. The state lab then does a series of evaluations of that blood for common metabolic problems, and I'll go with metabolic in a minute, what it means, that can be fixed. Because if you're testing for something that can't be fixed, there's a cost to that testing that really doesn't have a benefit right now. So when we say metabolic problems, what it means is somewhere in the workings of the body, something's not working well. So it could be that the red blood cell is being made abnormally, and we are looking for that. Sometimes the baby's thyroid functions are not working well. We can be looking for that. Some of the enzymes that the body uses to break down blood sugar, to break down protein, to break down fats, those things can be evaluated by those little 5 blood spots, because if it's picked up early, we can treat with diet or we can treat with medicine and treat those problems. So that's called the genetic disease screen. That is usually done at 24 hours of age. And then another one done about 5 days of age once you've gone home with your baby. And that will be determined and planned with your baby's doctor once you go home. Another thing that we do is we do the bilirubin screening. Bilirubin is the chemical that's in the bloodstream that causes babies to develop jaundice. Jaundice is the skin color when babies are yellow. It just means that the baby's liver, which is immature when they're born, it's immature for about 5 or 7 days, which is supposed to break down all those red blood cells that are in a baby's body, to break it down to normal red blood cells. If the liver is not able to break it down well enough, the skin can get yellow and that bilirubin can be elevated. And so if the bilirubin is elevated, it can get into the fluid around the brain and can cause developmental problems. And so we want to screen for that. Now, the biggest risk for babies is twofold. One, if a baby's premature, because their liver is even more premature or immature. So those babies are at risk of developing jaundice faster. Also, babies that mom has a blood type that's O or negative and their blood type is different, the mom can develop these chemicals in their bloodstream that fight baby's red cells and breaks those red cells down and makes that bilirubin come higher. And so that could be a problem, and those babies will.
It seems like we're having technical difficulties. I apologize, everybody. She should be back up in a minute. Don't believe it's going to come back on. I apologize, everybody. She was finishing up with the bilirubin screening that we do here. So that is a test that is done here before you go home, and then you follow up with your pediatrician later on. So I'm going to go ahead and conclude today's TMC Mama Chat. I'm sorry for the technical difficulties. We can pick up next week where we left off and finish discussing this. We will also have a discussion about postpartum depression next Thursday at 11 a.m. And we can revisit the newborn care and safety. Thank you for your time, and I hope you guys have a great day.